Hi, everyone. Welcome to our March policy briefing. I see Dr. Bates has joined, one of our speakers today, and so we're just waiting on Dr. Rodriguez, but oh, there he is. Hi, Dr. Bates. Oh, there's Dr. Rodriguez. Okay, we have both our speakers. Wanneh, you there too?
Yep, I'm with you now. Hi, everyone.
Great. Well, since we're keeping these monthly policy briefings to 30 minutes, we'll go ahead and get started, and I'll admit people as we go. I just wanted to say at the top that we want to keep these 30-minute briefings pretty informal. So welcome folks to chime in with questions and unmute yourselves, turn your video on as we go throughout. Wanneh and I have a few questions to kick off discussion with Dr. Bates and Dr. Rodriguez, but encourage you all to chime in as you have questions to ask. And I also just wanted to add that our monthly policy briefings are usually for eHI members only, but because of the general interest in this area, we've invited some guests to join that are not eHI members. So if you're not an eHI member and are interested in continuing to attend, feel free to reach out and ask about membership. Okay, well, without further ado, I will go ahead and introduce our guest speakers for this month. Dr. David Bates is an internationally renowned expert in using information technology to improve clinical, oh, sorry, I just lost my, here we go. Clinical decision-making, patient safety, quality of care, cost effectiveness, and outcomes assessment in medical practice. A practicing general internist at Brigham and Women's Hospital, Dr. Bates is chief of the Division of General Internal Medicine and Primary Care. He is a professor of medicine at Harvard Medical School and a professor of health policy and management at the Harvard T.H. Chan School of Public Health, where he co-directs the program in clinical effectiveness. He also serves as the medical director of clinical and quality analysis for Mass General Brigham. Welcome, Dr. Bates.
Thank you, Catherine.
Yeah, of course. So then we have Dr. Jorge Rodriguez. Dr. Rodriguez's research and passion lie in the meaningful intersection of medicine, social justice, and technology. He is a technology equity researcher and hospitalist in the Division of Internal Medicine and Primary Care at Brigham and Women's Hospital and Harvard Medical School. He completed his internal medicine training at Mass General Hospital, and he also completed a clinical informatics fellowship at Beth Israel Deaconess Medical Center. Prior to his current position, he was medical director of clinical informatics at Lawrence General Hospital, where he oversaw an electronic health record transition in a safety net hospital. And he is currently focused on bridging disparities in patient-facing health technology, including patient portal, mobile apps, and telehealth. Well, welcome to both of you. I'm excited to kick off our questions here. So to kick things off, can you both talk a little bit about your experiences using digital health tools to care for patients before the COVID-19 pandemic and since the COVID-19 pandemic, and what have been your experiences with addressing health disparities?
So maybe I'll just start. Before the pandemic, we were where a lot of other organizations are around the country with telehealth, which is that we were using a little bit, but we were really kind of dipping our toe in the water. People were seeing an occasional consultation via telehealth. And then when the pandemic started, we switched almost overnight to doing almost all of our outpatient care virtually. And we also started doing a lot of inpatient care virtually. Jorge, I think, talk some about that. So it was just a huge switch overnight. It was made very dramatically easier because of the because the restrictions around payment had been eased by the payer community, And one thing that became really clear is that many of our patients did not have the wherewithal to do video visits. They preferred doing telephonic visits. So we ended up doing a lot of telephonic visits, especially for older patients and patients who were at a disadvantage in some way.
Yeah, and I think I'll add that I agree that, but before the pandemic we were doing not very much, I think, with digital health tools in general. I think that and even with that though, we sort of knew a lot of the disparities that we saw in terms of access to whether it's telehealth or mobile apps or patient portals. We sort of knew those existed before the pandemic was here, and then they just sort of heightened those things. And then, the other thing before the pandemic, I always think back to a conversation I had with a group of primarily Spanish-speaking patients in a small community center, where we were talking to them about a patient portal, and we were, saying, with the patient portal, you can do all these great things. You can send secure messaging to your care team. You can review your medications. And it was very interesting, at least for me, to see that the patients were essentially like, that's great and all, but like, how does that help me with my food insecurity, my housing insecurity? So I think pre-pandemic, we were still kind of trying to figure out where exactly things were going to fit in. And I think post-pandemic, because access to care became such a critical piece of digital health tools in general, it just became a little bit more obvious. And I'm in story mode today, so I'll tell another story sort of connected to that. I was chatting with one of my colleagues, Dr. Rome, and he was telling me about this story where he had a patient that was scheduled for a virtual visit. I forget if it was telephone or video. It might have been telephone. And the patient, he was waiting for like a couple of minutes. The patient had not arrived yet for their visit. But one thing that was very striking to me, he was able to actually, using the telehealth platform, text the patient. The patient received the text, and the patient was like, you know what, I had actually forgotten because I had a bunch of other stuff going on. And now he was able to jump on. So what would usually be sort of like a missed appointment or a no show really became a way to sort of meet patients where they were and really deliver care within their community. So that always sticks with me as sort of like a post-pandemic story that I always find striking, as like where the opportunities are for a lot of these digital health tools to really engage our patients in sort of new ways.
Dr. Rodriguez, I have a question for you in that same line about reaching communities where they are. You've done some research around the availability of health apps in languages other than English, and you published a study in which you reviewed both app stores. In this study, you found that 30% of apps had descriptions available in Spanish, of which 41% of Android apps were available in Spanish, and 21% of iOS apps were available in Spanish. In addition, the readability of 94% for the App Store descriptions was above the recommended level for patient education material in English and Spanish. It seems that those who can potentially benefit from these tools are not able to access them right now. Can you talk more about this barrier?
Yeah, no, thank you for citing that study. I think that a lot of this really comes down to the sort of the premise of kind of digital health tools or health IT and to address health disparities. And I always think back to the work of Dr. Lenny Lopez over at UCSF, where his whole premise was that if you're going to really take health IT to address health disparities, you really have to start off with kind of two concepts. One of them is start off by knowing that you're going to aim to achieve health equity with this new health IT tool, and two, you have to really sort of engage and design for these populations that often need a lot of this support. And in this case, in our study we found that Spanish speakers, we often have worse outcomes, and sort of that extends more broadly to limited English proficient patients in general. Really, you would think if this was such a great tool, there would be like so many apps in Spanish and all sorts of different languages, especially for diabetes. But that was not the case, and I think it's been sort of a challenge of just the way we've developed health IT and digital health tools in general for a long time. And I think there's sort of opportunity now that we've seen that this can really be a central part of the way we deliver care, and it can really be a central part to like a health equity mission to really address. So for example, in this case for limited English proficient patients, I always think of like, from a policy perspective, our national guidelines on how to deliver linguistically appropriate care don't explicitly include what to do in terms of digital health tools. They sort of say, health in general, but how does that apply specifically to digital health tools? And I think on the hospital system side, as it relates to language, I think there's an opportunity to really push a lot of the vendors and the app makers to say upfront when you're kind of first having that initial engagement with them to say, hey, how did you sort of did you approach your development from a perspective of equity? Did your user testing include patients of different literacy, different language? Did it include integration of third parties, for example, for interpreters? Do you have offered in different language? So all these questions up front you can really ask to make sure that hospital systems are also playing their role in and sort of helping and collaborating with vendors to make sure that they're sort of developing these tools in an equitable fashion.
Absolutely, thank you for that.
Yeah, thank you, Dr. Rodriguez. I think that's an important point and something that we've focused on here with our policy work here at eHI, focusing on health equity and digital health tools, which is of course our focus for the conversation today. Is even if you have reimbursement and broadband, what are those other issues that are still a barrier to folks using digital health tools? So thank you. And I also, for those who have just joined, I wanted to say that feel free to chime in with any questions that you have as we go along. You're welcome to unmute yourself and ask the questions directly, turn on your camera. We want to keep it fairly informal at these policy briefings. So Dr. Bates, just turning it to you now. When we spoke last week, we actually had a chance to speak of some of these issues with our smaller group. You talked a bit about this issue, how digital health tools often don't benefit high-need, high-cost patients. And this is actually something I've thought a lot about, because private employer-sponsored insurers were more willing to adopt digital health tools like telehealth earlier on in this COVID-19 pandemic. But those tools that they used were mainly built to benefit their younger, healthier beneficiaries. And so do you think a broader and more accessible variety of digital health tools will emerge if the large government payers like Medicare and Medicaid expand reimbursement?
I think that's necessary, but not sufficient. And I'll just tell you about the findings of a couple of studies we've done in this area that were sponsored by the Commonwealth Fund. In one, we looked at health apps and looked at the broad array of health apps, and we found that for many high-cost, high-need kind of conditions, there really were not very many or any good apps that were targeted at those conditions. So if you have a condition like diabetes, there are lots of choices, but for many others, there are very few. And we then did a study together with Dr. Urmimala Sarkar at UCSF, in which we picked 4 conditions, gave patients and caregivers access to apps, and then had them actually try and use those apps. And people really struggled. So for example, among diabetics, only about half were able to even enter their blood sugar, which is about one of the more basic tasks. And yet, when we asked people afterwards, every single one of them said they really wanted to be using something like this to monitor their condition. They just felt like the current offerings didn't really meet their needs yet. So I think we're going to need some specific direction from policymakers if we're going to get to the point where many conditions are covered, and even those conditions that are covered have offerings that are going to help people really make care better. Germany is doing some very cool stuff in this area and in policy, and what they are doing is setting things up so that if an app maker can basically demonstrate some improvement in quality or outcomes with their app, then they can get that app reimbursed. And that is the sort of thing that provides a direct incentive to the developer community to build things that will actually make a difference.
That's interesting. Dr. Bates, just building off of that, it seems that there's a catch-22 debate happening right now with regards to digital health tools. Some are concerned that expanding reimbursement for these technologies further widens the digital divide, and some could be left behind. But on the other hand, the current policies where mainly private insurance company beneficiaries are the only ones able to utilize modern technology, they don't provide many options to vulnerable populations. However, leveling the reimbursement field won't address all these issues, clearly. What are some non-reimbursement policies you believe that could help address digital health equity?
I think it would be useful to support more evaluation of and development of technologies that are targeted specifically at disadvantaged populations. And then there are also an array of things that can be done in communities, for example, to expand access to things like digital navigators to make things work better. This is an area that Jorge has done a lot of work in and thinking about too.
Yeah.
Dr. Rodriguez, do you have anything to add to that? Sorry.
Yeah, I think I'll just add that I think that, I think there's a lot of opportunity here, at least from what we've experienced so far. A lot of the challenges have been sort of like one around sort of like the kind of the classic digital divide in terms of like access, like internet and device access. And so policies sort of supporting that in some way, whether it's things like the emergency broadband service that the FCC is rolling out currently to help patients with support their internet access or their device access. One thing, because I think from a healthcare system perspective, it's tough to play that role. Like there's like limited resources in the hospital. Unless reimbursement changes significantly, it's going to be hard for a hospital to say, every patient that I'm caring for, I'm going to offer them, a device and internet access at baseline. I mean, I suppose it could work, but in the current system, it doesn't quite work. So I think that's sort of one area. And I think just like Dr. Bates said, the sort of the digital health navigator or something addressing digital health literacy is really key. I think we have a pilot going right now at one of our clinics, and it's been very interesting. We're just a couple of weeks in, but it's been interesting to have a digital health navigator play a role and try to call patients and try to see if they want to join the patient portal or convert some of their telephone visits to video visits. And some patients are really like excited to do it. Some patients are like, it's also interesting to see like some patients are just not into it. They're like, we were just chatting the other day. They were just like, one patient was like, you know what, I don't have email and I'm kind of happy I don't have email. And you're like, okay, that's fine for you. Like that's, this is not going to be for everyone. So it was just kind of an interesting component. But I think that role of like digital health navigator or someone to have that conversation with patients, I think is key for this. And then the other thing that goes along with kind of this like digital literacy piece is really, there's so many other places within our communities that do literacy and adult literacy well, and the health system is not necessarily one of them. And so whether that's libraries or whether it's nonprofits that do this, or collaborating with local schools, community centers, so many other places where they've been working on adult literacy longer than the healthcare system has. So I think any sort of policy that either through financial support or grant support kind of helps those collaborations happen would go a long way. And then the last thing I can go off on, but the last thing I'll mention is sort of support for the actual infrastructure, much like there was the FCC had that program a few months ago, where there was sort of like infrastructure support for the actual community centers, where a lot of our underserved populations are getting their care, whether it's FQHCs or something of the like, making sure that on the clinic side, they have the ability to have the infrastructure of, if you have enough computers, the right bandwidth, if you're doing remote monitoring, the right remote monitoring software, I think is the other big thing that sort of extends beyond reimbursement.
Great, thank you. Jim, I see you. Did you have a question?
I did. How do we get to, let's say, all people with income under 25,000 a year, and show them how they can get these medical services for free or near free? And for example, in Chicago, it's a community health organization, and there are others that are clinics that take people that have low income and are needy. We have food stamps for food for people with low income. Can we have health stamps, or telemedicine stamps, or telehealth, or whatever, at least to talk to a doctor. I just wondered, is there something available for people to source? Do we have something, or Medicare, of course, is another one. I'll stop there.
Go ahead, Jorge.
Yeah, so I think, Jim, your point is well taken. I think you're hitting sort of the hammer on the nail there. I think it's really treating sort of digital health and digital health equity as another socio-determinant of health. I think you mentioned sort of food insecurity as one of them that we classically think about. And in this case, it's sort of, internet access, device access as sort of like key components of this. And you sort of touch upon two things that we do currently in the healthcare system that I think should be applied in the digital health space. Is sort of one is screening. So we often screen people for whether they have food insecurity or housing insecurity. So similarly, asking those questions up front as we're sort of seeing our patients. And two, then the screening, then there's a referral process. And right now there's not sort of like a food stamp or like an internet stamp or digital health stamp or something along those lines there's a few different sort of like private approaches to it in terms of like things like Comcast Essentials, and I think Verizon has something similar, and RCN has something similar. But I think there's a start with the emergency broadband service that the FCC just is in the process of rolling out, where they actually are supporting patients through subsidized internet and devices. And so that's something where I think I would feel as a healthcare system more easily being able to like, all right, I've identified you have sort of digital health needs. I'm going to refer you to this FCC program where you'll be able to get those filled. I've been a little bit kind of, not feeling great about being like, you have this need, let me refer you to this like private company and, give Comcast or RCN or Verizon or whoever it is more business. But I think that's you're sort of, noting the fact that this is a socio-determinant of health.
And we do not have things as well worked out in this area as we do in other areas. And the vaccine, especially the way it was managed here in Massachusetts, really underscored that. So basically, you could not sign up for a vaccine unless you could go to this website and spend a lot of time there in Massachusetts. And that was, really beyond what many people could do or handle, unless you're in a nursing home. If you're in a nursing home, someone came by and gave you the vaccine. But otherwise, lots of patients who were not very digitally savvy, really got a short stick, despite some efforts, for example, to locate places that people are being vaccinated in certain communities. There was this threshold thing. If you could not get on the web, you couldn't get a shot.
I think that your final points there are a really great plug for Wanneh Social Determinants of Health /analytics work group. Wanneh and I were actually talking on Monday about the possibility of using APIs to push community resources into providers' hands for those exact reasons that you were outlining, both of you.
Absolutely. Reaching people where they are. Absolutely. Yeah.
Go ahead. When you're done.
No, please, go ahead.
Yeah, go ahead.
Okay. That's a follow-up point. Very broadly, what our group is looking at is the Maslow hierarchy of needs. You're all familiar with that. So on the lowest level is the basic needs, and the working hypothesis is that we're working on is that and anybody under, I'll just say 25,000. Some people have 60,000, but it's a low income level. Anybody under there, why can't we provide the basic needs for free? Because there are organizations in the community that can do that. Like Community Health is one of them, where they get sufficient contributions in kind, which medical people, and in cash, in order to handle these types of services in the medical. And is that, you know, is that saying what to do? I go along with what Dr. Bates said in Massachusetts, because I'm basically computer literate myself. I could never get on there by web, but I basically called a doctor, and he said that, you know, family doctor, and he said he'll get you in, you know.
Yeah. Thank you so much for those comments, Jim. Those are very relevant to our conversation. Looking at the clock here, we have 5 minutes left, so I just wanted to see, do folks have any other questions for Dr. Bates and Dr. Rodriguez? You're more than welcome to put them in the chat box as well if you don't want to unmute yourself. If you have roofers outside of your window like I do here. Oh, work from home.
Yeah, I had the garbage truck go by.
Well, do we have a working paper? Do we have a working paper on this? If I'm somebody with, you know, $25,000 of income, I got a whole bunch of things that I can get from the community for free. I can get furniture, I can get computers, I can get food, and on and on and on. And obviously all these things have to do with health in one way or another. And then of course we have the telehealth, and so, you know, and so on. Is there a way to publish this from the you know, for, let's say, each community, or work with the state, city? Okay, I'm done.
No, I was just going to say, I'm glad that you asked that, because before we wrapped up here, I wanted to mention that we at eHI have been doing some policy development around these issues, health equity and digital health. And thanks to a conversation last week with Dr. Rodriguez and Dr. Bates, we have the skeleton of calling it digitally proposed act. It focuses on points that came up during the discussion around providing qualitative care support to patients through grants that would be available to FQHCs and rural health centers and community health centers and community mental health clinics. And so we are working through some policy development on that, but I will say that we've had some really great interest, bipartisan interest from the Hill so far. And so if you're an eHI member interested in learning more, please feel free to reach out to me. And then with that, with 3 minutes left, I'll let Wanneh plug her SDOH work group.
Thank you. I was also going to say, if you have questions about the work that we're doing around SDOH and health equity, please email me. At eHI, our programs and our policy, they go hand in hand. We definitely don't work in separate areas and in silos. And so Catherine and I, along with Alice, work very closely together and find these intersections between, a number of these issues. And I think with healthcare, finding more and more intersection with some of the, as we call them, the social determinants of health, recognizing that there is a link, and also making sure that policies take that into account. Some things you heard from, like Dr. Rodriguez with access, it's more than just providing the internet, it's providing the tools and providing the education. And I think from a community standpoint, it's bringing it to community-based organizations' attention that they do have a role in healthcare. And, so those are the things that we're focusing on with our equity and disparities work in the SDOH group and in our data analytics work group as well. So I'm going to put my email in the chat, and I'd love to hear from people to reach out to me.
Yeah, there's so much work to be done here. We are excited to be, a small part of it, focusing on how do you utilize data, ensure that's interoperable, and then also on the flip side, how do you ensure access to care? Are there any closing thoughts, Dr. Rodriguez or Dr. Bates? We're so thankful that you could join us today. I know you're both busy. I think Dr. Rodriguez, you're currently on a clinical shift right now, and I'm not sure, Dr. Bates, you might be too. So I really appreciate it.
And thank you for having us. I think this is great conversation.
I just would say that the pandemic has really underscored the importance of addressing some of the barriers to equity and showed that digital equity is just as important as some of these other types of equity, and may even be more important going forward. So we have to learn some things and make some changes.
Great. Well, if there aren't any other questions, I'll let you all go. I will let you know that our April policy briefing will be focused. We'll have a colleague, Alice Leiter, as Wanneh mentioned, is going to join us for another 30-minute discussion, and we're going to be focused on the new HIPAA proposed rule and the changes that are proposed from the HHS Office of Civil Rights to the HIPAA regulations, excuse me. I think these are the first major changes since the HITECH Act passed back in 2009. So it's a big deal. Join us. It'll be actually April 16th at this exact time, 3 to 3:30. And you'll, if you're an eHI member, you'll see the registration link going out soon. And again, if you're interested in becoming an eHI member to join these future great discussions, please reach out to us. And with that, everybody have a great afternoon.
Thank you, everyone.
Bye.
Bye.